Hello everybody and welcome to this webinar hosted by the Medicines Management team, giving you an introduction to the CQC framework. This is the first in a series of free webinars intended to improve CQC awareness and compliance for providers working across primary care. And after this first session, we'll then be focusing more on the SAFE key question, unpicking each of the 8 quality statements that sit beneath it, one per webinar. My name is Dr. Clare Sieber. I'm a working GP and clinical advisor here at the Medicines Management team. And let me introduce you now to the rest of the esteemed panel that you'll be hearing from today, whose experience will give you some broad viewpoints on the CQC framework, its impact on providers and its everyday application to us working in primary care. So Gabby, I'll hand over to you to introduce yourself, and then Gary and then Mateen to introduce yourselves as well. Thanks, Gabby.
Thanks, Claire. Hi, everybody. So yeah, my name is Gabby Ashton. I have a background in CQC compliance and quality assurance and looking at regulatory compliance across the health and social care sector. And I was a former CQC inspector for a number of years. So I now support providers with their ongoing CQC compliance and quality assurance frameworks.
Thanks, Gabby. Hi, I'm Gary Hughes. I've had over 17 years in primary care. My business is called Leadership in Practice, and through that I help practices, PCNs and federations be the best business they can be. I've been a practice manager, a PCN board director and founding director of a GP federation. Mateen?
Hello everyone, thank you Claire, and thank you everyone. So it's an absolute pleasure to be here. Thank you for the TMM team to invite me to this as well. I'm a doctor, GP partner at Elm Tree Medical Centre, have been for the last 5-6 years, and I'm a clinical advisor and do consultancy in primary care. Thank you.
Thanks, Mateen. Next slide, please, Gabby. So let us tell you just a little bit more about the Medicines Management team before we kick off in earnest, who are an award-winning provider of remote pharmacy services, and that's the company that's hosting these webinars to improve our CQC awareness and compliance. Rashad, do you want to take us through this?
Of course, yeah. Lovely to meet everybody. My name's Rashad. I am a pharmacist and an advanced clinical practitioner with many years' experience in primary care. I also work as a director at the Medicines Management team, where I manage the operations and, most importantly, the training and upskilling of pharmacists and pharmacy technicians to do good work in primary care. We deliver this through our training hubs, supported by GPs and senior pharmacists. Now, the Medicines Management team is essentially an award-winning provider of remote pharmacist and pharmacy technician services to GP practices and PCNs across the UK. We're proud to host this webinar to support GP practices, PCNs and service providers in becoming CQC confident, especially during a period of rapid change. We'll cut through the noise and connect you directly with the experts. This will be a live webinar series, including a Q&A session with the specialists with practical, actionable steps to help you strengthen compliance and feel CQC ready. Over to you, Claire.
Thanks, Rashad. So before we kick off, let me just give you a quick overview of what we'll be covering in today's session. We'll start by going back to the basics and reminding ourselves of what the CQC is, what it does and why it does what it does, and how it's got to where it is today, whether you think that's a good place that it's in or a not so great place that it's in. And touching on what Rashad said there about the ever-changing CQC landscape, we'll talk a little bit about the future direction of the CQC over the next few years, as far as we know anyway. And then we'll have a bit of an overview of the 5 key questions and a focus down on SAFE. And throughout the session, we'll be hearing from the expert panel and posing some questions to them. So that's the overview of today. Over to you, Gabby, now to start the session off properly.
Great, thanks, Claire. Okay, so the first part of the webinar that we're going to be looking at is focusing on the regulatory milestones and the key pieces of legislation that are in operation that underpin the CQC. It's really important for us to focus on these today and throughout the webinar series, because as the other members of the team have alluded to, there are changes that are happening across the CQC from a framework perspective, but what is not changing is the legislation that underpins that framework. So part of the demystifying and breaking down barriers and making sure that providers feel confident with being CQC compliant is making sure that they understand the legislation that underpins what the CQC do, how they operate, how they think, and how they then go on to inspect and regulate services. So we've got here the Care Quality Commission 2008 and the Associated Health and Social Care Act of 2008. So the 2008 Act brought health and social care together under one regulatory body, which created the Care Quality Commission. They were fully founded in April 2009, and it also incorporated the Mental Health Act Commission and the associated duties under the Mental Health Act of 1983, which have very recently changed, but we will talk about that later in our webinar series. So under the Health and Social Care Act of 2008, which formed the CQC, we have two key pieces of legislation to understand, and that's what we'll be focusing on today and throughout the conversations that we have with the team. So the first part is the Care Quality Commission Registrations Regulations of 2009. It's always a bit of a mouthful, but essentially this piece of legislation focuses on the notifications and other kind of requirements that providers are required to comply against from a notification or a notifiable incident perspective. We will come on to that in a little bit more detail shortly. And then we have the Health and Social Care Act 2008, Regulations 2014. So the original Health and Social Care Act from 2008 were updated in 2014 to include something known as the fundamental standards, which hopefully people have heard of, and if not, don't worry, that's what we'll be going through over this series. There are a number of fundamental standards that essentially outline what good care looks like, so sort of a baseline principle and a minimum requirement for what we would expect any health and social care provider to adhere to. And that's what we use when we look at the relevant, when we're thinking about inspecting, when we're thinking about possible enforcement action or breaches of regulations, we're looking at how providers meet the fundamental standards and whether or not they are complying with the Care Quality Commission 2009 regulations as well. So in terms of getting registered, just for those of you who have joined the webinar or a part of the webinar series that are thinking about whether or not they do need to be registered, whether or not they fall in scope, it's just worth thinking about what registration is and how that looks before you kind of then get started with your ongoing compliance journey. So there are some key things to think about from a registration perspective. We're thinking about exactly what registration is. We're thinking about your statement of purpose, which is a key document that any health or social care provider must keep a hold of and keep up to date as part of their ongoing journey with the CQC. Thinking about regulated activities and regulatory conditions that, again, you must kind of tick when you register and make sure that you adhere to, and notify the CQC of any changes there. And then we're going to talk about the roles of nominated individuals and registered managers for companies that are registered. So for the statement of purpose, as I mentioned, this is the key document. When you register with the CQC, you must submit this as part of your application, and then you must make sure that you keep this document live and kicking essentially throughout your journey being CQC registered. We'll touch on it again later, but your statement of purpose must be up to date at all times. If you make any changes to the way in which your business operates, so that might be details in relation to names or contact details of registered people, it might be your aims and objectives, the services that you provide or plan to provide, it might be the age groups or the service groups for people that you care and support for. If any of that changes, you must update your statement of purpose and then notify the CQC within 28 days of any such changes. When the CQC come out as part of their registration and as part of their ongoing inspections, they will be using this statement of purpose as sort of like a key document to understand how you're operating. And if they find that your statement of purpose is not conducive with the way in which you're operating, then that would be a breach under the registration regulations of 2009 that we spoke about. So your statement of purpose is made up of 4 parts. Part 1 is very much just the logistics. So thinking about the name of the business, looking at your legal status and any contact details such as address, telephone numbers, and email addresses. Then you've got part 2, which covers your aims and objectives. So that's where you get an opportunity to explain to the CQC what your kind of values and your aims and visions for the business are. Then you have part 3, which is looking at your location. So for each location that you want to register with the CQC, you need to be talking about, or you need to provide details about the address, contact details, description of that location from an accessibility perspective, and a setup point of view. And then you need to essentially tick which services you're hoping to provide. So which regulated activities, the types of service that you're looking to register, and the different needs of people that you will be providing health and social care services for. Then part 4 is looking at the registered manager. So this is where your registered manager would need to provide all of their information for you to submit at provider level. So you'd need their full contact details, the locations that they will be managing, the activities, and then any details of job share arrangements. So it can be quite a lengthy document depending on the level of service you provide, but again, we can support you to keep that up to date if you needed. In terms of your regulatory conditions, so there are a number of things that you need to complete as part of your application, and again, making sure that these are reviewed and kept up to date, even beyond your initial registration. That it does happen quite often where we go out to do mock inspections or audits for services, and actually they've changed the scope of service that they're providing, but they haven't kept their registration up to date, so they're in breach in a number of ways there. So you need to cover your regulated activity. For healthcare providers, you'll probably be familiar with the 2 key ones, which are treatment of disease, disorder and injury, and diagnostics and screening. But there are others such as family planning, surgical procedures, or if you're specialising in slimming clinics or slimming services, that you may also need to think about. So there's lots of information on the CQC website, but you do need to get your regulated activities correct. You've also then got your service types. So again, it's primary medical services. It might be if you're providing online services that you've got mobile doctor services, and there are then primary care specific boxes as well for you to complete. And then you've got your service user bands. So that's really the groups, age groups or types of groups of people that you'll be providing care for. So examples can include supporting people with dementia, physical and sensory impairments, mental health and learning disability and autism services. So again, as part of your registration, but also your ongoing CQC compliance, you're likely to have a nominated individual and a registered manager. And these are the 2 key roles that that the CQC are looking as part of the registration. They will be interviewing to look at their fitness to practice, and then when they do the mock inspections moving forward, they're looking to meet with the nominated individuals and the registered managers to understand how they demonstrate CQC compliance and how they delegate and kind of undertake their roles correctly. So the nominated individual acts as the key point of contact for the CQC. So their role is to ensure that the service is compliant with the legal and regulatory requirements, and they are responsible for overall governance and leadership of the service. Specifically, this includes supervising the registered manager and promoting high quality care through that support. So this is very much making sure that the registered manager has all of the resources and support that they need, and that's for the nominated individual to oversee. Then you have the registered manager. So this is the person who is appointed as someone who is in day-to-day charge of carrying on the regulated activity. So they're much more kind of hands-on, much more operational. Often there'll be, people that are either directly involved in or delegating and overseeing compliance with the fundamental standards and with the CQC Assessment Framework. So as the registered person, you have legal responsibilities in relation to this position, and you share legal responsibility for kind of meeting the requirements overall with the provider, so with the nominated individual. When the CQC inspect at registration stage. So when you have your interview, they're looking to make sure that the registered manager is of good character, and that they have the relevant qualifications, skills and experience, and that they can demonstrate knowledge and a clear plan of action of how they're going to oversee the day-to-day management of the regulated activities at the location. I think now we're just going to hand over to Claire, Gary and Mateen for their thoughts on these roles.
Thanks, Gabby. It's interesting, isn't it? Thinking about, now that we know this, what these roles actually mean in a little more detail, the nominated individual and the registered manager. You've got a nominated individual who has oversight and a kind of supervisory role. So in a traditional GP practice, it might be a partner that says, okay, that sounds like me, except that they are the key contact with the CQC, at which point probably a GP partner will say, okay, I don't want to be the key contact with the CQC. And then flipping it the other way, with the registered manager role being an operational role, that sounds like it would be more suited to a practice manager, because it's normally the practice managers that are more operational and the GP partners that are strategic and have the oversight. But then I wonder how many employed practice managers who have that operational role would feel really happy about taking on the legal responsibility of the CQC in the way that you understood. That sounds like something that I think some practice managers would feel more comfortable sitting with a partner. So it's a little bit of a conflict between these roles and the traditional roles that partners and practice managers have in practice. It's a bit of a mashup, I think. Gary, I'm interested to hear your thoughts, and then Mateen, about how you've seen it work in practice.
Yeah, I've seen practice managers that have been the registered manager, and also many that haven't. And when I was in practice, I wasn't the registered manager. Where I've seen the practice managers, registered manager, often they're not happy about it, and it's something that's forced on them. My own view is the registered manager, because of the legal responsibilities, should absolutely be the business owner. I don't think GP partners should even ask their practice manager to be the registered manager. They should take that responsibility on, unless, of course, the practice manager is a managing partner. So I think absolutely it should be the GP partner. You know, they are the business owner. They should take that legal responsibility. The nominated person absolutely makes sense to be, you know, the practice manager. Most of the communications into the practice for different things around CQC will come through the practice manager. Easier, a better flow, and be able to then be communicated out. So I think that role absolutely sits with the practice manager.
Thanks, Gary. So from your point of view, like the legal responsibility bit is the most important thing, and it flows from there. So the person with legal responsibility, i.e. the registered manager, then has to be the business owner, and then the other role goes to the employee.
Yeah, I think absolutely. You know, the GP partners, the contract holders, the business owners, you know, they have all of that responsibility, and this should, you know, sit with them as well. I think, you know, most definitely.
Thank you. Mateen, how about you? Have you had any thoughts on this, and how does it work at Elmtree?
I think, firstly, I think quite strong points from Gary there, and I tend to pretty much agree with him, if I'm being honest. So I think as a GP partner, you can look at things in a different way. From my perspective, I think delegation is essential. Let's be honest, as GP partners, we're relying on our practice managers, our lead GPs, or you know, salary GPs, pharmacists, the wider team, to run the different parts of the practice. We're not necessarily doing that on a day-to-day basis, but delegation doesn't really remove accountability. At the end of the day, we are accountable, because it is, I guess, we are the shareholders of the business. So the registered manager role is what, in my opinion, anchors that accountability to one named individual. I think in a busy practice like ours at Elmtree Medical Centre, multiple changes are happening always at the same time and quite a rapid pace. Staffing pressures, access models, winter pressures like we're going through right now, digital systems, clinical pathways are changing, SOPs are being made. Without a registered manager, it's easy for responsibility to sometimes get diluted, I feel. I think with one named person, and this is something we have in our practice, throughout the practice, not just with CQC, that it brings a lot of clarity on who's ultimately responsible for safety, quality, and compliance. Practically, for me, that means that when a risk is identified, whether it's around, it could be staffing levels, it could be about prescribing, it could be due to access, There's a clear escalation route. You know who to contact or who's responsible for it. So the registered manager then ensures the risks are logged, reviewed, and acted upon accordingly as well. And I think from a governance perspective, at the end, that specific role then allows the partners to focus on strategy and improvement, knowing there's a robust oversight in the background. Without that oversight and that accountability, you cannot look to the future, in my opinion, when you're managing an SME, like a medium-sized practice. So for the wider team, it creates confidence, in my opinion. People know who they can go to. They feel, in my opinion, supported to raise concerns and understand that safety and quality are being actively led by the owner of the practice, in this case, a GP partner.
Yeah, it's a really good point you make, that whatever way you do this, the doing of all of the CQC compliance is not going to sit with one person. Sure, the accountability, responsibility might do, but you've got to delegate, and it is ultimately everybody's business. And that's how the CQC want it to be. Every member of staff needs to be aware and involved. Otherwise, it doesn't work. Gary, did you want to come back in?
Yeah, I'm just going to completely agree with what Mateen's sort of said and what you've just sort of reiterated as well, the delegation part. You know, this works best, as so many things do in practice, when the partners and the practice managers are working together in harmony. So, you know, absolutely, for the GP partner to be the registered manager, but delegate much of it to the practice manager, and for them to be working together, absolutely, that's the way that it will work best. So, you know, yeah, agree with that point about delegation, and that's how I've seen it work best.
Thanks, Gary. Back to you, Gabby, for thoughts, and then carrying on.
Yeah, my thoughts are that sometimes, and this isn't obviously a blanket approach to all, but when I hear that the registered manager is a GP partner, my heart does sink a little bit. That's a very honest thought, but good to have a team to unpick that with. Because if delegation isn't managed really, really well, what you often find is then you're looking to the registered manager for answers about CQC compliance, about, you know, the day-to-day activities of the regulated activity, and they don't know the answer. And they don't really, and if you do come across that, where they not only do they not know the answer, but they don't know how the delegation is being clearly managed. So, okay, that's the practice manager's role. Okay, it might not be their job, their legal responsibility, their kind of formal job, but it's been delegated in such a way that they don't have that working relationship together, they don't have that communication channel. And then if you're not assured that the registered manager doesn't know how things are working, then you're immediately facing concerns from a regulatory and compliance perspective. So yeah, it's interesting for Gary and Mateen to say that the practice manager shouldn't be the registered manager, because from my experience, that's actually when it's worked the best, but only when they've had very strong support from the partners as the nominated individuals. So yeah, so I guess we have completely different opinions, which is fantastic, and it shows really that there's no right or wrong way to do it. And I'm sure that all the practice managers listening to this will agree with Gary and Mateen. But yeah, I think having that really robust delegation is so important. Otherwise, there's no assurance that the registered manager is actually in day-to-day charge of the regulated activity.
I think it's a fair point, and thank you for expressing your opinions. And I think it's good to have your opinions, because you've been on the front line, you've seen different practices as well. I think, from my opinion, I think it depends on individuals. At the end of the day, a good GP partner should have a very solid understanding of what the operations aspect of their practice is, and a working acknowledgement of what CQC requirements are. That doesn't mean that every single partner needs to be hands-on with day-to-day management, but they should be able to take a step back and see how operation safety and governance actually fit together as a whole. How this looks in practice does depend on the individual partner, in my opinion. I think probably it's a bit of both, isn't it? So it should be the partners, I guess, taking their accountability, but there should be an open communication between partners and managers. And I think that open communication is what makes it work, or what's made it work for us anyway. I think some visits or inspections may not go too well, and that needs to be discussed. Honestly, rather than defensively, if a practice has faced CQC repercussions, for example. Equally though, not every single manager will be strong in every single area. So I think that transparency and honesty is key.
So it sounds like there's a kind of fundamental different way of interpreting these descriptions, whether you're a provider, and when you look at those descriptions, the thing that sticks out is a legal responsibility, and then you allocate those roles based on that. Whereas when the CQC look at it, the bit that sticks out from those descriptions is the operational bit, which if you've then given that role of registered manager meant to be operational oversight to a partner, then that's where it might become difficult, because that partner then, when grilled in the CQC inspection, as that's how often sometimes people feel, then they might not have the operational knowledge that the CQC are looking for a registered manager to have, and then it can fall apart a little bit and the CQC might sort of prick their ears up a bit. Interesting, thank you.
Yeah, very interesting. Yeah, look forward to more discussions. So we're just going to unpick the legislation in a little bit more detail now before we move on to the current assessment framework that exists for the CQC. So I mentioned initially we've got the CQC, so the Care Quality Commission Registrations Regulations of 2009, which essentially are the notifications that are required. So across the next 3 slides, what we've done is we've recorded all of the regulations that fall under this piece of legislation, and then we've highlighted in yellow the ones that are specifically notifiable incidents or things that you must notify the CQC about. So we're not going to go into detail in all of these just because, you know, the slides are available and the information is there for you. But essentially we're looking at things such as I mentioned earlier, notifying the CQC of any changes to your statement of purpose within 28 days. If you have any planned or unplanned absences for registered providers or registered managers, then you need to notify the CQC. Any deaths in relation to people who, any people who have passed away whilst in receipt of a regulated activity, or which may have resulted from the carrying on of a regulated activity. You've got notifications in relation to serious injuries, allocations of abuse from a safeguarding perspective, incidents where there may have been a police involvement or police investigation, and any incidents that may prevent or appear to prevent the service from running smoothly or being able to continue or provide the regulated activity for a period of time. You've then also got the death of a service provider and anything relating to your financial situation, so such as bankruptcy of an organisation, or if you go into liquidation, anything like that. So there are a number of notifications to consider, and they're all highlighted there for you to have a look at. The Health and Social Care Act 2008, otherwise what I call the fundamental standards, we've recorded here. So we've got, when we look at the legislation, it does start from 1, but essentially we're only really focusing from 4 down to 20A. So 4, 5 and 6 look at the legal requirements in relation to the different roles, so specifically directors, providers or nominated individuals that we have just spoken about. Then looking at the requirements related to registered manager, which is number 7. Regulation 8 very much just says focus on all of the other regulations, so it's a more of a general approach. And then the meat and the bones of the assessment framework and the inspections that the CQC undertake are looking at regulation 9 down to 20A. So we're covering topics such as person-centred care, looking at dignity and respect, consent, so following principles of the Mental Capacity Act and how we obtain and record consent, thinking about safety and safeguarding, looking at nutrition and hydration, premises and equipment, complaints, good governance, which we previously focused on in the well-led webinar series that we did last year. And then we look at staffing, fit and proper staff, duty of candour, and then you're making sure that you display your ratings as a legal requirement. So part of and we'll come on to it in a little bit more detail very shortly, but part of the webinar series that we'll be looking at, because we're focusing on the key question safe, it makes sense that the majority of the discussions and the topics that we will be having will fall under Regulation 12, which is about safety. But what I always find really fascinating and interesting and enjoyable about CQC compliance is that actually the more that we talk and the more conversations that we have, you will find that one particular area of safety actually also covers looking at making sure that consent is robust, making sure that you're keeping people safe from harm, making sure that your staff are supported, qualified and fit to complete their roles, making sure that you're following duty of candour principles. So you may always think that you're focusing on one particular topic, but before you know it, if you're getting things right and you're being thorough, you're actually covering the fundamental standards in quite a lot of detail. So the CQC Assessment Framework, this is currently how it stands, and it's important to, well, we have got a slide about the future plans for the CQC later on, but it's just important to highlight that this particular framework is what exists now, and there aren't any plans for this to change for at least 2026 and 2027 while the CQC are in a period of change and consultation and review. So for now, this is what we have. So we have the fundamental standards, as I mentioned, the Health and Social Care Act 2008, and we have the notifiable incidents or the notifications that are required, which are the CQC Registration Regulations of 2009. So if we get those two right, then we've got the CQC kind of understood. Underneath that, the assessment framework currently stands as 5 key questions. So we have safe, effective, caring, responsive and well-led. And then underneath each of those 5 key questions, we have quality statements with a total of 34. And then underneath that, each of the key questions will receive a rating of outstanding, good, requires improvement or inadequate. And this is currently based on a scoring system of 1 to 4. So the quality statements, the 34 quality statements that the CQC look at, are essentially commitments that providers and system leaders should live up to. So they are expressed as we statements, and they show what's needed to deliver high quality and person-centred care. And they essentially provide guidance, details, lots of links to best practice guidance and legislation about how you need to work together to plan and deliver this high quality care to people. They have replaced the key lines of inquiry. Hopefully we're not still talking about Chloe's, but if you are, please don't, and talk about quality statements instead. We've still got a few legacy policies out there that talk about Chloe's. So yeah, the quality statements have replaced the Chloe's. And as Claire's mentioned, and as part of this webinar series, we're going to be looking at the key question SAFE, so your purple box, and the 8 webinars looking at each of the 8 quality statements that fall underneath that. So I won't read this out, but this is essentially a description of SAFE from the CQC assessment framework, and there is a description for each of the 5 key questions. And as I mentioned, what you then have are quality statements that fall under each of the key questions. So this slide, it does look overwhelming, but we'll unpick it and then we'll hear from the rest of the team as well. This essentially shows the 8 quality statements that fall under the key question of SAFE. And then under each of the quality statements, what the CQC have kindly done for us is link the legislation. So they've linked the Health and Social Care Act of 2008, or otherwise known as the fundamental standards. And where relevant, they will also link the notification requirements of 2009 for us. So this is really helpful because you will see just from having a glance at this that actually when we think about, we're starting at Regulation 9, looking at person-centred care, and we go all the way down to Regulation 20, which is duty of candour, you will see very quickly from this that we are looking at 9, 10, 12, 13, 15, 17, 18. So a lot of the fundamental standards, the majority of them in fact, are actually covered in one key question and across these 8 quality statements. So by the end of this webinar series, hopefully providers will have a really clear understanding of what it means to be CQC compliant with this key question, these quality statements, and actually a wealth of the fundamental standards that sit underneath it. So we're going to hand over now to Claire, Gary and Mateen again for their thoughts on this.
Thanks, Gabby. If you could whiz back just to the definition of SAFE, so it's on the screen for people. I mean, what I sort of picked up from that is they're looking for safety to be like this golden thread and central theme of absolutely everything that a provider does. It's like in the forefront of your mind. And I think we're pretty good at doing that from a service delivery point of view with the care that we're giving patients. But we also are expected to have safety at the forefront of our minds with all of our sort of internal business functions as well. And maybe that's the bit that's sometimes a bit more forgotten. What are your thoughts, Gary? And then I'll come to you, Mateen.
Yeah, it's huge, isn't it? I think, SAFE, when you're talking of business functions and governance and everything that happens outside of consulting room. I think a lot of it is going to be sort of supported by all your policies and protocols and everything that you've got. But of course, they get put on paper and then they get put on a shelf and never looked at again. So I think a lot of it comes down to probably the training, the induction, and making sure that you're monitoring what's happening and you're reporting on these to make sure that you are always working in a safe way. And whatever those standards are that determine you're safe, that they're being met. And I think, that needs to be sort of monitored and, sort of reported on. And there are some great frameworks that you can use. There's, for all of this sort of governance side of things that will determine whether you're safe, whether that's clinical governance or business governance. There's a framework called the 7 Pillars of Clinical Governance, and any clinicians listening to this will know that one. And I also use the 7 Pillars of Business Governance that will also sort of determine and help if you're safe in more in areas that are non-clinical, things like the information governance and those sorts of areas. So yeah, there's plenty you can do, but I think sort of making sure that those standards which should be doing, sort of making sure that they're embedded through inductions, training, and then monitoring and reporting on those.
Thanks, Gary. Mateen, how does that description look to you? Daunting or?
Sorry, no, it's interesting, isn't it? I think again, it's different perspectives and in different positions you might have, I guess, different view on things. At the end of the day, I can talk about from my practice point of view how we look at it. We treat safety as everyone's job. So we were talking before about accountability, where a practice manager, where they might have accountability and where a GP partner may have accountability as a registered manager. But here, in my opinion, safety is everyone's job, so everyone's accountable. And it shouldn't be a policy statement. Again, Gary's alluding to writing SOPs and putting them on shelves. It does happen, let's be honest about it. But as partners, we make this real by running weekly huddles in our practice with our clinical and admin team, often sometimes together, and having an open discussion, discussing the near misses, discussing patients' complaints, taking them seriously, prescription problems that you might face, and nothing's really off the limits in these discussions. And there's no real blame culture, and that blame culture is often said in meetings, but often not reciprocated. But in our practice, we try and do that as much as possible. We try and include everyone in it, often sometimes prompting people to kind of say something. And I think one example that I can share from practice point of view is, so we noticed a pattern of medication queries from patients with complex conditions. Instead of telling individuals to be just more careful, we brought pharmacists, reception team, GPs together to make an SOP to make sure that work wasn't duplicated, safe prescribing was happening, and adequate prescribing was happening, so the patient wasn't forced to over request and their needs were being met as well. Different patients may have different needs. So we redesigned the workflow, making sure all the key stakeholders were involved. And so pharmacists handled medication reconciliation proactively, and GP had I guess, protected time for reviewing those drug interactions for complicated patients. And I think that kind of example is something that tells you about what started off as a risk, then essentially became a learning experience that improved not only the safety, but also in the future, you would hope, cut repeated incidents. So something like this, in my opinion, that's how we would consider safe. So something that isn't working well and making it work well, not just for operational aspects in the practice, but making sure that the patient's in the middle of it. So most importantly, we encourage patient involvement. So we actively engage in PPGs. When a patient does flag a concern, be it clinical or non-clinical, most often, the first response is to often understand it and not be in a defensive culture in your practice where you're trying to understand it from the patient's perspective. And that mindset, in my opinion, will keep your practice safe and make sure that safety is at the central point of any discussion that you may be having, which will impact patient care.
Thank you, Mateen. I think that's a great example of what we'll do on the next webinar, which is the first quality statement. Yeah, Gabby's nodding, of SAFE, which is called Learning Culture, which is all about exactly what you talked about there, as per what Gabby's showing you on the screen. Just before we move on, Rashad, can I come to you, and maybe you'd like to share how Medicines Management Team, with its supply of pharmacy technicians and clinical pharmacist services to practices and PCNs, helps those practices and PCNs with the safety aspects?
Absolutely. Just echoing Mateen and Gary, really, I think safety is fundamental. It has to be built into systems, processes and protocols from the design stage, but it also has to actually be actioned. So it needs to be embedded as a value and a culture where safe working is actually promoted and supported in an organisation, and where safety is a priority for everyone, not just management. And I think the question safe has loads of different meanings depending on who you're talking to. And I think Mateen alluded to this, really, which is why there's 8 quality statements, and Gabby's going to run through the series, flesh it out, and literally go through what's needed to deliver high quality patient-centred care safely. An example that comes to mind is, as a company, around 3 to 4 years ago, we decided to update our processes of handling errors and incidents by pharmacists and pharmacy technicians. Now, we decided to track incidents and errors and review them monthly via dashboard, which we invested in, to see if it can help us identify trends, reoccurring risks. And what we quickly noticed was patterns, and it helps identify, for example, pharmacy technicians were struggling with task work and were making more errors when compared to pharmacists. And as a result, we increased training time and supervision period for pharmacy technicians, and that resulted in safer working. Now, without a system and designing safety into protocols, guidance and policies and how you're working, it would have been easily missed, because you have your day-to-day pressures which you're dealing with, which is why building safety into guidance is so important. And also, I think it was mentioned, removing the blame is essential, as that makes people really defensive from my experience. And just treating an incident as a learning opportunity was a game changer for our organisation. It just meant loads more reporting, better reflections, and it just reduced errors and shared learning as a company.
Thank you, Rashad.
Over to you, Claire.
Thank you. I think loads of reporting means that you're safe and you have a good learning culture. Not many reports probably means that people don't feel able to speak, not that there are issues and mistakes and things that could be improved on, because there always are, aren't there? We're humans. Absolutely. And we're working in a difficult, complicated system. Over to you, Gabby, for your thoughts, and then you can take us through a bit more.
Yeah, that was fantastic for me. It's a real reminder. I think it's fascinating, and actually what this webinar already today has done is highlight, I think Rashad said it, about different safety means different things depending on who you are. And yes, we can talk about processes, we can talk about systems, we can talk about governance and building in, correct systems and having daily huddles and handovers. One thing that really sticks out for me when we go back to this key question is thinking about patients' best interests. And Mateen, Gary and Rashad have all said it, that, we have to remember that yes, we can have all these fantastic systems in place, but it is ultimately the patient that we're considering and putting first. So I think I'm going to be including some questions in the webinar series to the panel about how the patients have been considered in all of these quality statements, because often, when I'm out on inspection, I very much hear about how providers have, that we can talk the talk, so we can hear about the daily huddles and we look at the minutes or the note taking from that and the steps that have been taken in the patient's best interest, or to protect the patient from harm or to keep them safe. What we rarely see is at what point was the patient consulted in that decision making. So how do we know it's in their best interests, or what level of consent or input or decision making do they have in that process? Or are we just deciding what's safe on behalf of people? Because as clinical leads and clinical experts and, from practice managers, kind of operational and, service delivery experts, are we just deciding what's best for people from a safety perspective? So I think that's something that we'll try and challenge and hopefully hear from the team about throughout this webinar series, so that we are hearing both sides of the coin, internal governance and systems, but also the patient input as well. So I won't focus on these, but for the purpose of the webinar, everyone will have access to these slides. So these are the descriptions of the remaining 4 key questions. So we have the effective, caring, responsive, and well-led key questions. And we've also just got a little bit of information here for people about how the current assessment framework works. So in a nutshell, it's a low score equals low quality. So an inadequate service would receive a score of 1 under the key questions, and an outstanding service would receive a score of 4 under the key questions. The CQC then total them all together, put in a fancy little calculator, which anyone can develop. It's not actually too fancy, and you come out with a percentage of what you would be from a rating perspective. So again, when I'm out and about working with providers, I always encourage them to use this scoring system themselves. It doesn't have to be something that only the CQC use. There's no reason why this can't be built into your own internal QA systems, your QA framework, so that you are regularly scoring yourself and benchmarking yourself against the assessment framework. This is how the assessment framework currently stands. So just some guidance and information for people about how inspections look, how information is gathered, and the frequency of assessments. By now, most people will have experienced what the new assessment framework looks like, whether that be through an inspection, so a comprehensive inspection, some smaller levels of data gathering, or the fact that they haven't had an assessment or an inspection at all, which indicates low risk, and that therefore the CQC aren't coming out to see them. So just some information here for people. And then what we've got just a slide here about the assessment framework, so the plans for the future. So across December, so just last month, and November as well, the CQC did hold some consultations with anyone could join to speak to the CQC from the different sectors, so hospitals, mental health services, primary care, adult social care, etc. They were all able to join in some consultations and listen to the proposed changes that the CQC are going to be introducing. We know from kind of updates from the CQC that these changes will take some time. There's not going to be nothing immediate. So as I mentioned at the beginning of the webinar, they've kind of committed to reviewing things in a bit more detail in 2026, but nothing will be rolled out from a formal assessment change point of view until the end of the following year into 2028. So we have got some time left with this existing assessment framework. So some of the key things that they've proposed is to reintroduce rating characteristics. For those of you who remember the Chloe days, there were actually some fantastic resources about what each Chloe meant in practice. So there were characteristics and descriptions. There was a draft that was produced by the CQC for the quality statements, but they're going to commit to providing more detail. And as part of that, looking at a framework to support providers with their ongoing compliance. They're looking to reintroduce assessment frameworks that are specific to each sector. So at the moment, it's known as the single or the assessment framework, because essentially all those 34 quality statements that we've spoken about cover all sectors. So it's the same for adult social care as it is for hospitals, as it is for GP practices. So they're talking about introducing sector-specific frameworks again. They're going to be looking at having more clear follow-up principles, so looking at inspections that will follow a more clear cycle depending on the ratings that you've had, which again, for those of you who have been registered for long enough will remember that used to happen. And then to no longer have scores underneath each of the quality statements, so they'll be separating those, they'll be separating the way in which they score. So a few changes. Obviously we'll keep you up to date as part of each webinar about in terms of real time what the CQC are letting us know, and it's worth keeping an eye on their website as well for any updates. But we'll hand over now again to the team to get their thoughts.
Thank you, Gabby. Interesting to hear what they're looking to change. I think from my point of view, there are a couple of things that stood out. This change to give more detail about what they're actually looking for is helpful, because I always hear practices saying, why can't they just tell us what we need to do? And this is one step closer to that. Practices often feel like it's like the first part is almost like a trick or a riddle they have to solve to work out what they're asking for, and then, okay, now we'll get on and do it. So that should make that easier, although it might not be as close to telling us what to do as we would perhaps want, but it might be closer than where we are now. And then the other thing about moving away from the same framework being applied to everybody, whether you're a small practice with one partner or a large hospital trust, will probably feel better for practices. I think practices have been feeling perhaps it's unfair to have the same expectations placed on them as a large hospital trust. But we've got to understand that the Health and Social Care Act still exists. That's not being tweaked, which is what the CQC are regulating us against. And that applies to us all equally, whether we're a small practice or a large trust. So I don't know if it will necessarily mean that providers are set different standards based upon their size or the sector that they're working in. And of course, it won't address the inconsistency that we sometimes hear from practices about inspections in primary care and how one practice is told this and another is told that. Interested to hear your thoughts, Gary, and then Mateen.
Yeah, where you ended there, Claire, is sort of the thought in my mind. Practices always grumble about the inconsistency, from one practice to another. And one part of me looks at this and I just think, okay, well, maybe it'll help with that. Maybe there'll be a bit more consistency and, that will help. But the cynic in me sort of suspects, probably won't be. I think if this adds some clarity to what practices are expected to do and it looks like it might, then that's a good thing. I think that's a good thing. And one message that I know sort of, Gabby always says is don't leave this to the last minute, make meeting your CQC requirements business as usual. So if this makes it clearer that you know what you've got to do, then build it into your business as usual. And we've talked about this with SAFE as well. So I hope it adds some clarity. I hope it adds consistency. The cynic in me says, well, let's wait and see.
Always a cynic. And how about you, Mateen? What about specifically the, being a bit more clear about the follow-up and the cycles and how frequently practices are going to be inspected? What are your thoughts on these proposed changes, Mateen?
Yeah, no, I agree with the points raised. I like how Gary puts his points across as well. I think so. So having a regular cycle is good, and I think it's fair as well. Why do some practices have to wait 10 years to go through a CQC cycle, and some practices get one maybe in 4 years' time, right? So I think for me, what's particularly interesting going forward is the clear approach to follow up and re-inspection. So if we know that the re-inspection is going to happen between 3 to 5 year cycle, depending on different types of services and the quality, then you can plan ahead. Now, ideally, you should be CQC good throughout the 3 years anyway, but I think just having some clarity will help. I think inconsistency is key, isn't it? And I think if one practice says, oh, well, the CQC assess us in this way, and then you think, well, they didn't assess us in that way, that's where the grumbling starts. That's where people get unhappy. So I think reducing inconsistency, and that to me will only come about what you alluded to, Claire, right at this conversation, is providing clarity. And you said it yourself, we probably don't have that clarity that we would like. It's better, but it's still not there. So I think inconsistently tends to creep in when expectations can't clearly be written out and understood in plain English or in detail. So hopefully that can be rectified in the future.
Back to you, Gabby.
Great, thank you. I suppose I'm a little bit like Gary. I should, even though I'm in the business of demystifying the CQC, I sometimes think be careful what you wish for, because depending on the level of detail provided, sometimes it never feels like enough for providers. And actually, if we just strip it back to the basics, which are the fundamental standards and the legislation, then that is open to not negotiation, but it's open for us to demonstrate how we meet that. Whereas the more descriptive that the CQC get for us, I actually sometimes find it then more restrictive for us to demonstrate compliance. We'll see what the details look like over the next couple of years. So we're ready to wrap up. We're just going to talk about a top tip that for anyone who's heard me do webinars or do inspections before, talk about, which is the 3 Ps. So this is the approach that I use to inspecting and thinking about good governance and ongoing compliance, and something that we'll be kind of holding on to throughout the webinar series, which is thinking about your people, so your patients and people that receive the regulated activities and the services, your personnel, so that says personal, but it should say, sorry, personnel, so your workforce, essentially, thinking about your staff teams and those that you employ, and then your processes, your policies, and your paperwork. And we'll be talking about how all 3 corners of the triangle are joined up. And actually, if there is a gap in any of those 3 Ps, then you are likely to be requires improvement, or certainly have an area of concern. So we'll be supporting you to understand how you can join up those 3 Ps and draw your good triangle, if not an outstanding triangle, throughout your CQC compliance journey. So looking ahead to 2026, here we are. We've got the CQC compliance, making safety a priority. So that's going to be our webinar series covering the 8 quality statements in detail. We'll be looking at the legislation. We'll be looking at some examples of CQC reports that have been published. We'll be looking at some top tips from frameworks or existing best practice guidance to help people. And then we'll be going to the panel for their thoughts and picking apart their brains a little bit with some inspector-led questions as well. So I'll hand over to Claire now to wrap us up.
Thank you, Gabby. So hopefully that's been useful for everybody, and we now have a better idea of what CQC is and why they're doing what they do, how to set ourselves up appropriately with registration and the named individuals, and keep up to date with our statements of purpose and why we need to do that. Understood the current framework and how that might be changing in the next few years until 2028. And we focused down on safe a little bit. And I love the tip about the 3 Ps. It's really helpful. So you could have the world's best significant events policy, but if you've got a member of staff that gets interviewed on the day of the inspection who can't remember any significant event ever being discussed, then that's one of your Ps not being met, and the whole thing falls apart. Do join us on our next webinar when we'll look at that first quality statement that we mentioned earlier, which is called learning culture, and Gabby will unpick it and give us some good examples and some not so good examples, and we'll talk through those in more detail. It's been great to see you, and we look forward to seeing you again soon.